Thanks for taking the time to listen to this podcast, which is aimed at all doctors and all ward nurses in the digestive diseases and thoracics, otherwise known as DDT, Directorate based at QMC. It aims to explain the system of ward-based working in our directorate, both the principles and the practicalities. If we don't all understand it and then adhere to it, it won't work. It's particularly important for our F1 and F2 doctors, who have particularly seemed to struggle to grasp it since its introduction a year ago. This may well be because it has not been explained sufficiently clearly, hence this podcast. So while F1 and F2 induction would seem a particularly pertinent time to describe the changes, it's also vital that the ward nurses and the more senior doctors in the various DDT teams based at QMC understand the detail of how ward-based working works and embrace the spirit of it too, hence its wider circulation to these groups. A subject like ward-based working is bound to be rather dry, and the words induction and entertaining are rarely to be found in the same sentence. But the content is important, so please do persevere with it and even concentrate on it. The misunderstandings about how it should work and who has what responsibilities have led to a significant and unnecessary degree of patients' inconvenience and frustration. The traditional model of patient care in the DDT Directorate at QMC, in particular within the subset of general surgery, had it that nurses were based on specific wards, while doctors of all grades were based in a surgical team, be that a colorectal team, or HPB, or vascular, or emergency. The now 1 year old and therefore not quite so new model of working within general surgery has it that the ward nurses and now the F1s and F2s are based on a specific ward. In contrast, the more senior doctors, i.e. the core trainees or CTs, the SHOs in old money, the specialist trainees or STs, better known as specialist registrars, and the consultants all continue to be team-based, i.e. they reside within one of the colorectal, HPB, vascular or emergency teams. So why was the change made? Well, first of all, different teams have different numbers of patients requiring different intensities of care. Ward-based working smooths out what used to be very large differences between different teams and also fluctuations within teams over time. Secondly, because both the ward nurses and foundation doctors are ward-based, it should allow for closer and stronger relations between these two groups. Third, there's much less need for having to repeatedly go from A to B to C, wasting substantial time in the process. Fourth, and of particular importance to the so-called outlying wards, most notably F22, the standard of care and the timeliness of care of the patients placed on these outlying wards will be substantially improved. Finally, it's a trust goal to achieve the practice of ward-based working throughout the hospital. Are there any disadvantages? Well, the straightforward answer is yes. Many senior doctors perceive a reduced sense of cohesion within the team, while F1s may sense a loss of belonging, with a loss of the camaraderie that may go with that. This might be summarised by saying that rather than being a member of a single team, F1s are almost certain to have to liaise with two or more different teams during their working day, while SPRs and consultants have to learn to work alongside many more different individual F1s. However, in the increasingly frenetic world of ever shorter patient stays, allied to modern technological medicine in a tertiary referral centre that handles very large numbers of surgical emergencies, including major trauma, not to mention the European Working Time Directive, the net benefits to patients undoubtedly favours the ward-based rather than the team-based model of F1 working. There are 6 specialist teams within the DDT Directorate at QMC. They're the General Surgery Emergency Team, the Colorectal Surgery Team, the Hepatobiliary or HPB Surgery Team, the Vascular Surgery Team, and within Medical Gastroenterology are 2 teams, Hepatology and finally luminal gastroenterology with clinical nutrition. There are also 6 specialist wards under the umbrella of DDT. These are C31, E14, E15, E16, F21 and F22, which also includes the clinical nutrition unit. Now, the ward-based model of care means that we have to have a contingency for our patients who are located on wards that don't fall under the umbrella of DDT. There are 3 principal wards where this situation may arise. They are E12, the surgical high dependency unit, the adult intensive care unit, and C30, the major trauma ward. Generally, relatively few of a team's patients are on one or more of these 3 wards at any one time. The emergency general team and the HPB teams are the 2 biggest users of these so-called level 2 and level 3 wards. You will hear more about the arrangements for managing our patients on these wards shortly. As you will have guessed by the way this presentation is going, there is very substantial overlap between the specialist teams and their base wards. Without this overlap, ward-based working simply would not work. Furthermore, senior nurses and bed managers are very aware of the importance of placing the correct specialty patient on the correct ward to maximise this overlap. But unfortunately, this can't be achieved all the time. The overlap works in that the majority of the general emergency surgery patients, particularly the shorter stay patients, will be on C31. Likewise, the majority of the colorectal surgery patients will be on E14. And the same applies with HPB patients on E15, vascular patients on E16, hepatology patients on F21, and finally the luminal gastro patients on F22, as I say, the ward that houses the clinical nutrition unit. At this stage, I want to concentrate a little on the organisation and deployment of the F1s and what your 4 months with us in general surgery will involve. First of all, there are 17 of you F1s. 6 will have been allocated by the deanery to the colorectal team, 5 to the HPB team and 4 to vascular. These 15 junior doctors, as well as the 2 F1s allocated to work with the elective neurosurgery team, will gain exposure to emergencies, as is required by the GMC, through working with the emergency general surgery team at QMC for a proportion of your 4-month attachment here. The 10 general surgery F1s based at the City Hospital, where there is no emergency general surgery, are also required by the GMC to gain that exposure to emergency surgical care. So, in addition to the 17 F1s based at the QMC, these 10 City Hospital based F1s will also be allocated to the emergency team here, both for their training and their accreditation. This does create a timetabling imbalance that can only be solved by occasionally allocating city-based F1s to work with the elective specialist teams at QMC. We recognise that this creates a lack of continuity for all parties, so this timetabling of city F1s to the QMC elective general surgery is kept to the absolute minimum. So how will you spend your 4 months as a general surgery F1 at QMC? Well, we'll start with the best news. You'll have 2 separate timetabled weeks of annual leave, and these weeks can be changed by agreement with Cat Moore, your junior doctor coordinator, but only if it does not impact on minimum staffing levels. You will also have up to 3 further weeks of off days. These are individual days in the week that are timetabled as a day off, largely to keep your hours of work within the constraints of the European Working Time Directive. They tend to be mainly Wednesdays and Thursdays because Mondays and Fridays are the busiest days, and Tuesday is the day of your mandatory F1 teaching. They don't help with providing continuity of care, but needs must. 1 week will be spent in the preoperative assessment unit, and you'll have a brief talk about that role later on in this induction, but most of the detail that you will require for managing during that week will be provided by that unit's very supportive staff on the Monday morning of your week there. About 5 weeks will be spent in hours with one of the non-emergency specialist teams, i.e. colorectal, HPB or vascular. And this will usually be with the team to which the deanery allocated you at the beginning. The complexities of the timetable and the necessary influx of the City Hospital F1s that I've just explained mean that link can't always be achieved. But Kat, who produces the rota, understands the real importance of maximising this continuity and does her very best. I've talked a bit about in hours and out of hours. You will know much of this already, but this slide serves to compare and contrast the two. In hours is Monday to Friday 8 to 5, which amounts to just 45 of the 160 hours in the week. During this time, there are fully staffed emergency and elective general surgery services, i.e. there's the emergency general, the HPB, the vascular, and the elective colorectal services all functioning. 4 F1s are with the emergency service and 2 F1s with each of the colorectal, HPB, and vascular teams. The 11th F1 will be with the preoperative assessment unit. Because it is less intense than out-of-hours work, there is no hospital at night support. Communication is largely done via ward-based, as opposed to individually owned bleeps. Out-of-hours, on the other hand, is the remaining 123 hours, almost 70% of the total hours in the week. Out of hours is made up of the twilight 5 to 8 p.m. shifts, as well as the nights and the weekends. There is no elective service operating during this time. There will be between 2 and 4 F1s during the night and at weekends. And you will be supported by the very experienced nursing and clinical support worker staff that make up hospital at night, better thought of as a hospital out of hours, since the weekend daytime is at least as busy as any of the night shifts. Communication during this time is via BlackBerry. So let's start with how you're organised during the in-hours period. The F1s attached to the elective specialist teams, colorectal, HPB and vascular, will be based on E14, E15 and E16 respectively. And there will be 2 of you, one of whom will be working a regular day from 8 till 5, while the other works from 8 through to 8, i.e. through the twilight shift till handover to the night team. This is a deliberate arrangement to encourage joint working between the two, with a view to allowing for the normal day person to leave at 5 o'clock promptly. Of course, we are all professionals responsible for patient well-being, and there will be times when you both need to stay beyond 5. But assuming reasonable time management and clinical skills, this should very much be the exception rather than the rule. The emergency F1s will be based on C31, and there are 2 emergency teams. One is known as the General Stroke GI team, while the other is the emergency part of the HPB team. Each of these teams will be led by a specific consultant of the week. But, and this is a very important point, the remaining grades, i.e. the 2 SPRs, the 2 SHO equivalents and the 4 F1s will work across both teams to ensure that all patients are seen and managed as soon as possible. The needs and circumstances of the emergency service can be very varied, and therefore all 4 of the general GI consultant and the HPB consultant and both of the SPRs will need to provide leadership on C31 to ensure that the perennial misery for patients of prolonged waits and endless repetition of clerking is kept to an absolute minimum. Teamwork, particularly, and time management are both vital skills that all of us need to be reflecting on during our day-to-day work and always striving to improve. This is particularly important at the beginning of your career, and there is no better and no more important place to learn these skills as an F1 than on C31. Finally, we take hours of work in the Directorate seriously, and we will be monitoring them prospectively over a 2-week period during this attachment. In addition to that process, I expect you to tell Kat whenever you have stayed significantly late and to explain the reasons why. Collating and presenting this sort of information will also be the responsibility of whichever of you volunteer, I hope, to join our Junior Doctor Forum, a body that we've recently created to help us try to understand and then fix the inevitable problems faced by all of our juniors. But we can only do that with your help. Now we come to the crux, that is, what are your roles and your responsibilities? Well, there is both a clinical and an administrative component, and both are important. Starting with the clinical aspect, first and foremost, you are responsible for the management of all, i.e. both surgical and medical patients on your allocated ward for that week, or part of that week if you have scheduled off days. Secondly, you are also responsible for the management of what is usually relatively few of your team's patients who are based on the non-DDT wards, i.e. those on E12, intensive care and C30. In actual fact, intensive care has its own junior staff, so this additional patient responsibility will only really apply to those patients on E12 and C30. Thirdly, one of the two F1s will attend the morning ward round of all the other teams that have patients on your ward. The senior members of those visiting, for want of a better word, teams, will need to seek you out for what is likely to be a relatively small ward round, and new F1s will need to be on the lookout for these visiting teams too. It is neither acceptable for the visiting teams nor for the ward F1s, and certainly not for that team's patients, for the round to be done without the F1 present. That is because verbal face-to-face communication is both better for patient care and also much better for trainee education. During the remainder of the day, you will deal with both purely clinical, for example, the required review of ill or deteriorating patients, as well as part clinical, part administrative tasks, such as completion of summaries, organisation of investigations, etc. Finally, and again very importantly, there will also be an afternoon board round by your ward specialist team at 4 o'clock. Ideally, both F1s will attend that, but if only one is available, it should obviously be the long day F1 to avoid an unnecessary handover. As regards the purely administrative aspect, you will be responsible for the accurate management and timely updating of your team's complete patient list. So the E14 F1s will maintain a list of all the colorectal patients wherever they are in the hospital. For your team's patients housed on the other DDT wards, you will rely on your ward specialist registrar and consultant to keep you updated. A particularly important part of this administrative job is ensuring that the correct patient is attributed to the correct consultant, both on your list and by liaising with the ward receptionist on the PAS system. I will touch on some of the most important aspects of your roles and responsibilities in a separate talk that I will give shortly, called the 10 Do's of being an F1. So what will the format of the specialist round be? Well, of course this slide carries a health warning attached because there will always be variations between different teams. And the inevitably unpredictable nature of the emergency service means that this description may well not apply to the emergency ward rounds. But using the colorectal team and the E14 F1s and the E14 nurses as an example, the team ward round, colorectal in this case, will start on the team's base ward, E14 in this case, at 8 a.m. It will be led by what is often referred to as the senior decision maker, which may be a specialist registrar or maybe a consultant, and will include both E14 ward F1s and one of the ward nurses, wherever possible, the nurse in charge. That ward round will see all of the team's own, in this case colorectal patients on E14, and on the vast majority of days, the majority of the patients on E14 will indeed belong to the colorectal team. When all the colorectal patients on E14 have been seen, the round will move to any of the non-DDT wards housing colorectal patients. This round will be accompanied by one of the two E14 F1s. Meanwhile, the second E14 F1 will remain on E14 to do any necessary jobs and to join the other DDT ward rounds as and when they arrive. Returning to the colorectal ward round that has moved on to the non-DDT wards, this round is accompanied by one of the two E14 F1s. Having seen all your patients on these wards, the ward round will move on, but the F1 will stay on those wards to complete any jobs, including, where applicable, e-summaries and TTOs, for those patients prior to returning to E14, the base ward. Meanwhile, the colorectal ward round will then visit the remaining DDT wards where they have patients. Just to recap, the 6 DDT wards are E14, E15, E16, C31, F21 and F22. And this round must be joined by one of the two F1s based on that ward, and also, in most circumstances, by one of the nurses on that ward. If for any reason a nurse is unable to accompany that round, the senior decision maker will find the nurse in charge and report on all patients seen prior to leaving the ward. Finally, the colorectal round will return to E14 so that the colorectal team list can be appropriately updated. And of course, this might very well be a time for a visit to the mess for some sustenance and some cross-checking / allocation of jobs to be done. The afternoon team round will take place on your team's base ward at 4 p.m. and is a verbal board round of all the team's patients on that ward. As well as both F1s and the SPR or consultant, the nurse in charge should almost always be present at this board round. If circumstances dictate that only one F1 can attend, it should be the long day F1 to avoid any need for further handover. And while there may be need to be a physical review of one or two selected patients, it is primarily a process of verbal review. This review will be based on information gained by the F1s from any blood, radiological and or endoscopic investigations done during the day, along with any clinical progress reports. As such, this is an ideal training opportunity. F1 doctors need to learn the skill of concise presentation, not only of factual information, but also your interpretation of that information and how that may have altered your management of the patient. It is this processing, rather than just the gathering of that information and its formulation into a coherent management plan, that constitutes decision making. And this opportunity to make decisions on a day-to-day basis in circumstances of reasonable safety, i.e. where you can have it either ratified or challenged by your SPR or consultant, is one that you must not let go. In my experience, the doctors who fail are those doctors that have never faced up to the often difficult and often uncertain business of decision making. And if you don't begin to do it as an F1, it becomes doubly difficult as an F2, and so on. In the majority of instances, it will not be necessary for outlying teams to do afternoon board rounds, since the patients of any team that have been placed on outlying wards should be the least sick of the patients within that team. Ill or high maintenance patients should always be repatriated to their team's home ward at the earliest opportunity. While we all want patients moved as little as possible within the hospital, outlying patients can be a real patient safety issue. As such, it is the responsibility of the team leaders, not the F1s, to liaise with bed managers and the so-called on-call silver nursing and managerial staff to ensure that where necessary, this repatriation does occur and at the earliest possible opportunity. There will be a presentation shortly from Hospital at Night, so I will show only one brief slide on out-of-hours organisation. The ward-based model is largely retained for the twilight shift between 5 and 8 p.m. Monday to Friday. However, if there is any lack of clarity as to which F1 should be seeing a patient or to whom the patient should be escalated during this period, the Hospital at Night team will be able to arbitrate. While hospital at night is technically responsible for the allocation of jobs between 5 p.m. and 8 p.m, the retention of the ward-based model during these times means that in practice they will be relatively infrequently involved before 8 p.m. on weekdays. Even during the weekend and night parts of out of hours, hospital at night has no role in one particular area. That is, the emergency surgery admissions. In the same way that hospital at night has no role in the management of the medical emergency admissions to B3 and D57, it similarly has no role in the management of both our surgical emergency admissions to C31 and our emergency inpatients on C31. These patients are admitted and managed by the F1 based on C31 and the rest of the emergency surgery team and C31 nursing staff without input from hospital at night. However, hospital at night does take on a large and a very important role in the management of the remainder of the general surgery service, both at weekends and at night, when the ward-based model is no longer operational. At the weekend, between 8 a.m. and midday on both Saturday and Sunday, when several surgical ward rounds are taking place simultaneously, there are 4 F1s available. Between midday and 8 p.m, there are 3 general surgery F1s on call. 2 manage the non-C31 surgical patients, largely based on the E and F floor wards, while 1 manages the patient on C31. At night, when only 2 F1s are on call, the non-C31 patients are managed by 1 and the C31 patients by the other. Just 2 slides to go. One is on the key to high quality patient care, that is effective communication. This is primarily a slide aimed at our senior decision makers, particularly our SPRs. But you F1s also need to be aware of what it says, and that is 1. Don't start the ward round till the whole team is present, i.e. both the F1s and a member of the nursing staff. 2. During the ward round, make absolutely sure that the F1s and nurse know what is required for each patient, why it's required, and the degree of urgency, i.e. by what time it needs to be done. Particularly in the emergency setting, there is a real need for us senior medics to set the time parameters by which things need to be done, and to state the action required of the F1 if that goal is not achieved in the required time frame. This action will almost always be referral back to us for our hopefully heavier weight input to what requires to be done. On the subject of ensuring that the F1 knows what is required, it is particularly important that the senior decision maker on a ward round gets into the habit of looking at what is being recorded in the notes in his or her name. There is very often a major disconnect between what you, the SPR or consultant, think you're saying and what the F1 thinks that you're saying and is recording on your behalf. When that disconnect occurs, and it's much more likely when things are rushed, there is usually responsibility on both sides, and both sides need to be aware of the need to take responsibility for either correcting it or ensuring it doesn't happen. And then, after the ward round, make sure that those that need to be updated are updated. And finally, the most important advice and the most important instruction. If in doubt, ask. So I anticipate that this will have thrown up 1 or 2 questions, although I hope it has been clear, and please feel free to feed back on the content of it. And also, anyone who's interested, please let me know whether you would be keen to volunteer as a participant in the Junior Doctor Forum that I referred to in this talk. So you can email me at mike.robinson@nuh.nhs.uk. Thank you.